Thank you. Yes, I think that provides a really great context for the rest of the day today. And we're getting ready to get a little more narrow focus on mobile phones for health promotion, which kind of gets more of a focus on mHealth. And I read a quote this morning on a blog on my iPhone that said to think of mHealth as personal health reform, which I thought was great because it can be refreshing for us to think about personal health reform this morning as the rest of the nation is in a struggle over national health reform. So our first speaker is from just down the road. Kelly Langle is a health behavior and education scientist with over 20 years of experience in the health sector. And since 2011, she's been with FHI 360, where she leads reproductive health research in developing countries. Kelly is FHI 360's leading expert on mHealth communication technologies and research, and she is expert in developing, testing, and evaluating health communication materials and interventions. Kelly has expertise in research and evaluation, digital and social media, adolescent health, higher risk populations, substance use, HIV and family planning, communication, and knowledge management. So let's give a round of applause for Dr. Langle.
So to start, is my slide presentation up? Oh, fun. Can y'all hear me? Yes, very great. So good morning to everyone. I am Kelly Langle from FHI 360 Family Health International. We are a health and development organization. We have offices in 60 countries around the world. I am a behavioral scientist at FHI. I've been working in the field of mobile phones for health, or what we call mHealth, since about 2007, 2008. It is a pleasure to be here on this wild ride we've had this morning, which has been awesome. We've had a really nice, or at least I feel like we've had a nice diversity of speakers talking about different aspects of e-health. And so I'm going to take us, we're going to go east or west, as you will, to sub-Saharan Africa mostly, although I'm going to talk a little bit about some data from the United States. So I'm really going to focus on this use of mobile phones among research in research-poor settings. So let's see if I can. So as I said, I've been working in mobile phones for health since 2007, 2008. And the idea for the work that I and my team at FHI started doing really came from work that we were doing with family planning or contraception users in East and West Africa. And what we were seeing was that a lot of people were having problems getting information to essential information about family planning and about services where they could actually acquire family planning methods. And so as you see in this graph on the left, we really do have these severe shortages of health workers in a lot of areas in the world, primarily in these black areas you see here in sub-Saharan Africa. And so since you oftentimes have to get information from health workers in these settings, we really do have just a critical lack of information and access. And at the same time that we were doing this research with family planning users in 2007 and 2008, we were starting to really notice at the time that people were having mobile phones. And so when you look at stats globally, in 2000, there were 719 million mobile phone subscriptions, and by 2011, this had increased to 6 billion mobile phone subscriptions. And so we now estimate that over 80% of the world's population has access to a mobile phone, and in fact, many more people now have access to a mobile phone than to clear water, good sanitation, electricity, or a bank account. One thing that I do want to emphasize as I go forward with this is that I work primarily in sub-Saharan Africa, though I also do some work in the United States. And mobile phone use, it really is different in sub-Saharan Africa in developing countries than it is in the United States, and I think that that'll come out a little bit as I share some of the data I'm going to share. But I think that's just something to keep in mind, and it's something for this community to really, think about what are those differences, what are they, how real are they, what are they primarily based in, what do they mean for health promotion, for health systems improvement. So when we think about this lack of access to information and we combine it with this growth, dramatic growth in mobile phones, we see these enormous opportunities for global mobile health or mHealth solutions. And so this is just a couple of the different ways that we see mobile phones being used worldwide. And they really are used for all kinds of things, health management, information systems, electronic records, point-of-care provider tools. Mobile phones provide a new communication channel for our health campaigns. Many people use mobile phones for m-banking, and just to be clear what that is, m-banking is essentially used, it's banking for people who don't have formal bank accounts, and so it's using your phone to send and receive money. And this is very, very common in developing countries. It's common in the United States among certain subpopulations too. So I want to talk for just a minute about a program we started in 2009. It's called Mobile for Reproductive Health. This is an SMS, entirely text message-based system. It's interactive or ping pong. It's menu-driven, which means that you receive a message and you respond with a keyword, and then you get a message back. And so it's ping pong. You can go back and forth as much as you'd like. So this particular program contains information about family planning. We have information that really is standardized. It is not tailored at all. It's based on WHO guidelines for essential information about family planning methods. We provide information in 2 to 3 SMS screens for 9 different family planning methods. And then we also have an SMS searchable database where you enter the first 3 or 4 letters of a district or ward that you're in your country, and you'll get back the location of services, of health facilities where you can get family planning services. M4H is an opt-in or on-demand program, so we have these incredibly strong partnerships in all the countries where M4H is operating. So it's promoted at the clinic level, it's promoted at the community level, it's promoted at the mass media level. And we have piloted and now scaled up something that we call embedded evaluation via SMS. So our speakers this morning, several of them are referring to really using mobile phones to track your users or to track outcomes to collect data. And that's what we've done with this embedded evaluation. I'll show you some of the results that we've gotten from that on the next slide. But essentially what we do is we automatically send text questions, open-end and close-ended questions, to all of our M4H users 2 or 3 days after they initially access this text messaging system. We ask them age, we ask them gender, we ask them how has M4H affected your use of family planning, things like that. And we've achieved incredible response rates, up to 50–55% of all of our M4H users. So in a 3-month period, we can get 60,000 pieces of data coming back. So it's pretty robust in terms of monitoring and evaluation. So M4H, it was launched in 2009. It was launched in Kenya and Tanzania. We've now adapted it for young people in Rwanda. So it's covering sex and pregnancy, puberty. We have HIV and STI messaging. It's also been scaled and adapted in other countries. In Mozambique, there's a group of Peace Corps volunteers in Nicaragua who saw this and said, oh, we want to adopt this for healthcare workers, things like that. So just to see what kind of data you can get, and I think maybe this can provide an illustration a little bit of what a couple of the speakers this morning were talking about. So just to show you reach, the 2 pie charts are from Kenya users. These represent, I think, about 4,000 people in each pie chart. And what you see is that M4H in Kenya during this time period was reaching primarily people 29 and younger. And then also we had about a 60-40 split of men to women. And then the figure on the right is Tanzania. This is data collected over a 6-month period. This represents about 25,000 M4H users. And what you can see here is that M4H was used by 127 out of the 129 districts in Tanzania. So we had 98% reach of M4H in Tanzania during the 6-month period. And so what's really exciting is A, you can use this method of data collection for monitoring and evaluation, and B, these data really demonstrate that we're able to reach really underserved populations, young people, men, rural populations, that type of thing. So that leads me to a CFAR Developmental Award that I hold with my colleague Betsy Kostenbutter, who is in the audience here today. We have been really interested in how we can use mobile phones to support underserved populations, because we've learned from our other mobile phone research that phones really do provide this incredible opportunity. That there's a lot of hype around them, but a lot of that hype is actually real. And so we were provided a developmental grant to conduct formative research on using mobile phones to support linkages to healthcare and treatment among substance abusing populations. We have 3 goals for this. The first is to investigate ownership and use of mobile phones among substance abusing populations. Second of all, to obtain reactions to messaging to support linkages to healthcare services and healthcare support. And then third, we're hoping that these data we've collected are promising enough and indicate that we could write a compelling project proposal for an NIH program announcement that is to look at technology-based interventions to promote engagement in care and treatment adherence for substance abusing populations with HIV. So we have actually just finished collecting these data. So I'm going to tell you about those in a second, and just bear with me because this is all very fresh. So it's the first time we're talking about it because we really just finished running some quick data analyses. So both of these, the formative research was conducted as a part of 2 larger studies. So the first is an alcohol harm reduction intervention among female sex workers in Mombasa, Kenya. It is a PEPFAR, or Public Health Evaluation Study. This was the first wave of the Implementation Science Awards that PEPFAR was providing for its programs. It's a randomized control trial with behavioral and clinical outcomes. We enrolled 818 female sex workers with hazardous or harmful alcohol use. And so we have gone back to sample some of them for focus groups for the CFAR study. And the second study is empirically testing network sampling strategies in unbounded risk populations. My co-PI on this award, Betsy Kostenbutter, is the PI for this NIH study. It's a social network study of substance users in Dar es Salaam, Tanzania, and also Atlanta, Georgia. And so they surveyed 540 people in phase 1, equally split between Dar and Atlanta, and then conducted an additional 50 interviews with people in high-risk venues in Dar and 50 in Atlanta for our CFAR data. And like I said, we did 6 focus groups with our alcohol-using female sex workers in Mombasa. So on the left, you can see a picture of our sex workers in these focus group settings, and then on the right, you can see some community mapping. It's a little hard to see on here that they've been doing in the social network study. So just quickly, like I said, this data is new, but let me tell you a little bit about what we're actually learning. So looking at the focus group data, when we look at phone ownership and use, mobile phones are absolutely essential for sex workers. And we're seeing this in the Atlanta and Dar data too, and I think this is a really key population that using mobile phones for support is a really, really good idea. So many of the sex workers have multiple SIM cards. Those are the cards that if you work in developing countries, you know what they are, but that's where our data, your data, like your phone numbers and stuff, is held. It's put into your phone. It would be an unlocked phone is what we call it here. So sex workers have multiple SIM cards, multiple mobile phones, often one that they use just for their clients, and a second one that is for their family and friends to communicate with. And most of them are keeping their phone numbers for a long time, even if their phones are changing often, sometimes because they're stolen or they steal them or all kinds of different things like that. And then when we look at what's the ability to reach them with messaging, first of all, there's little phone sharing among sex workers. You can see a quote here about that, so that you could send them private confidential information. They usually have at least one battery charge, so a phone might be in silent mode when they're working. They are heavy text messengers, also using their phones for voice. Also, some of them use mobile Facebook and M-Pesa, which is the mobile banking. Some of them have smartphones, but generally they have basic phones or feature phones, so you're limited in terms of what technology platforms you can leverage to reach them. And then when asked if you'd like to get health information via mobile, they said definitely yes, but it needs to be free. We'd like to get it a couple times a day, and we'll actually forward this information to our friends. So looking at our survey data in Tanzania and Atlanta, what we see here around ownership is that some people have multiple phones. That was something that we learned here, more so in Dar than Atlanta, that most people are likely to own their phone for more than a year, but also importantly, up to about 25% actually have had a mobile phone for less than 6 months. So for follow-up or tracking or reachability purposes, there might be some challenges there. And then when we look at trying to reach these populations with messaging, we find that, first of all, they're not sharing their phones either. So again, you could reach them with confidential private messaging. Heavy use of, most would be reachable. So you can see that in terms of the proportion that can talk or text all or most of the time, the large majority say that they can do that. They are using their phones for SMS, for texting across the board. Mobile banking is very popular in DAR, and then also for alarms, playing games, some mobile Facebook, and then asked if they would pay attention to health text. Again, the large majority said yes, definitely. So then just in conclusion, this data is really new, so I'm just going to quickly summarize this. And please know that we would really appreciate your input, feedback, thoughts on this, since it is all so new, and we're actually hoping to develop it into a new project proposal. So you can reach some high-risk and substance-using populations through mobile phones. You probably can't reach all of them, but sex workers in particularly are attached to their mobile phones. There's high use of SMS or text messaging in all of the samples that we surveyed. They're using a variety of phones in mobile network operators, which would have challenges if you were looking for a public-private partnership where you just wanted to partner with one telecom company, right? Then you're really going to limit your ability to reach people in these populations. And then finally, health techs are highly welcomed by everyone that was included in this formative research. So in terms of intervention approaches, clearly providing health messaging via SMS seems like a good methodology. A second methodology or second approach which we're interested in, which I actually wanted to ask our previous Seth and Deb about, is this kind of supporting health communities via SMS. So taking that kind of social support that we're leveraging in our counseling and interventions on the web, things like that. And technologically speaking, how could we do this via SMS? This is something that our sex workers in Kenya talked about and said, it would be really great if we could have this SMS linkages where we could talk to each other and learn from other sex workers and learn when are we able to get free health services and what's the hospital doing and things like that. And then finally, this using incentives or vouchers through mobile banking. This is something that we are currently exploring in our Mobile for Reproductive Health program, where our hypothesis is if you provide kind of an incentive for someone who uses M4H, and it's an electronic voucher where they can get a free or reduced or a discount on a family planning method, then would they be more likely to actually go and into the health facility and actually adopt a method? And so that type of kind of conditional or cash transfer approach is something that is definitely worth exploring. So that is it. And like I said, I would love to hear what people think about this. And so if you would talk to me and Betsy at lunch, that would be great. Thank you.
Thank you, Kelly. So next up is another one of our neighbors from down the highway. Dr. Brian Southwell is Senior Research Scientist at RTI International in Research Triangle Park. He also holds faculty appointments here at UNC and also at Duke University. And prior to moving to North Carolina in 2011, Brian served almost a decade at the University of Minnesota and has also worked for a variety of nonprofit and governmental organizations. His research has been funded by the National Science Foundation, the National Institutes of Health, and other sources. And his research and theoretical contributions appear or will soon appear in more than 70 peer-reviewed journal articles, chapters, and proceedings and publications such as Social Science and Medicine, Communication Theory, and Communication Research. And he's also the author of a new book published by Johns Hopkins University Press. He's presently senior editor for Health Communication and is a member of 6 other editorial boards. His work has been recognized with numerous awards for distinguished scholarship and for exemplary teaching. Let's give him a hand.
Thanks so much. My goal this morning is to be relatively pithy and also hopefully somewhat provocative. We only have a few minutes to talk, and so what I thought I would do is to try to pose a couple of ideas and questions and considerations for us to engage in a bit of discussion as we move to the Q&A session after these presentations. A lot of really great work going on this morning, and I certainly applaud the conference organizers in pulling this together. And we're all talking at a point at which this is quite exciting. We're at a moment where some of the demographic digital divides that we've worried about for a long time are seemingly melting away, and where it does seem to be possible to do this work to reach various audiences. At the same time, I think that there are some theoretical caveats and nuances worth pointing out, and I want to do that with a few minutes that I have. Specifically, while I will raise an example with regards to an SNS program that we are working on over at RTI, I want to spend a few minutes talking theoretically about recruitment to intervention and ways in which we might use a variety of new technologies in order to get people to the table. Because I think that an exploration of some considerations in that regard might be revealing and useful for us to think about. So stepping back then, I'm kind of thinking broadly about some of the technologies that are available. I think there are some ways that we might be able to group them in terms of thinking about ways that we can advertise intervention, think about the mundane task of recruitment, but also that's a task that I think has wider application in all kinds of ways that we can discuss. So the first that we might consider is actually a relatively old notion, but one that now you might think about banner ads and other opportunities via the internet in a targeted and rational way, but nonetheless to broadcast and advertise intervention. And I'm going to talk about an example of that a bit later on. It's now the case, though, that we're also increasingly excited about peer-to-peer connections. These are social connections that have been with us for eons, and at the same time, we now have access to technologies that seemingly make it much more possible to forward information to one another, to get in touch with one another, and to bring them also to the table for interventions. Kelly referenced one example of that. We can talk about that a little bit later on as well. And then we also might think about what we might deem or label leveraged search. But by this I mean finding ways to optimize and to interact with search results for those that are actively seeking information, to put notice of intervention in front of them, and to ensure that you are finding a way to tap into the myriad search activities that are going on daily. With regards to all three of these, I think there are some caveats that we ought to point out, and that's what I'd like to do here. So first, let's talk just for a minute about the notion of social networks. This is something that people have gotten quite excited about, and there's good reason for that. And we can think about ways in which perhaps these networks may be tapped for recruitment. Here's a way in which we are able to imagine you have a foothold in a particular network and are able to get access to the rest of the people in that network in ways that maybe are different than conventional broadcast means. For me, this is both simultaneously exciting and at the same time an avenue that's really fraught with challenges and actually even ethical concerns, and concerns that I want to put square on the table. Some of this is summarized in a book that literally is just out a couple of weeks ago from Johns Hopkins, in which we explore, and I explore, the royal we there, I guess, explore the notion of social networks as a strategy that health and science communication professionals might leverage. And there's certainly plenty in the book to be optimistic about, but there also are some basic principles of networks that are worth exploring as well. In fact, I outline at least three constraints that we might think about at different levels of organization. We might think about differences between people, not demographically in the way that we conventionally do, but differences between people in our tendency or willingness to share information with others. And undoubtedly, this room, for example, there's quite a bit of variance in that regard. Some of us, just by temperament and personality, are going to be much more likely than others to engage social media, to engage interpersonal conversation, to share and disclose information. And that's going to have distinct implications for the degree to which we can leverage those ties in terms of thinking about recruitment. It's also the case that certain topics are more or less likely to be shared. So here we might think about some of the conditions and diseases that are highly stigmatized that many of us worry about and are working on. And we can ask questions about whether or not we can draw lessons from the commercial sector, lessons from everyday Facebook patterns, and necessarily apply them to stigmatized conditions. Because it may well be the case that we're seeing certain patterns of sharing which are really different than what we might see when you're talking about disclosure of information about oneself, or by targeting someone or arousing a stigmatized topic of discussion or taboo. Okay. And then the last consideration that we might think about has to do with the nature of networks themselves. And here, I want us just to keep in mind the very simple but nonetheless powerful and important idea that all networks are not created equal, right? And that they're going to differ quite radically. We see examples of this in the network literature all the time. The notion of preferential attachment is going to suggest that there are going to be, relatively speaking, winners and losers when it comes to regard to network nodes. We're going to see certain nodes that are attractive and that over time are more likely to gain in connections than others. This is both a phenomenon we see in all kinds of aspects of the natural world, but one that really has important implications. An example of this, just to kind of illustrate this idea, actually it came to me and it was perfectly illustrated a couple of years ago at an outdoor concert, which I had the pleasure of attending with my wife. And at this concert, one of the more mundane aspects of it are the porta potties that we see at all types of these events. Well, why do I raise it in an example like this? What actually happened, and this is fascinating to see, you can see I never quite turn off the social scientist in myself even at these concerts, but there was a very long line at the first couple of these porta potties. Right? What was really, and it wasn't actually these porta potties, but this is an example, but the line that was there, so this line was clustered and grew, and people kept queuing on those first couple of lines. There was an entire bank, literally right next door to them, in which they were virtually empty, as it was sort of further away from the concert venue. So, a rational approach to this might have suggested, uniform distribution of folks across each of these, and yet you somehow see clustering at those first couple on the basis of the notion that I think people thought that they needed to be gathering where others had already started to gather. Okay? And so over time, this grew and grew and grew, and you see through preferential attachment unequal distribution in this network of, or queue of lines. Well, similarly, this is going to happen in many different places in the natural universe, and it happens in information settings all the time as well. Okay? There have been good and important studies online recently thinking about the impact of having some momentum with degree of likes, for example, on a Facebook post or comments, and that attracting more attention over time than maybe is warranted just by virtue of looking at the content itself. That has implication for recruitment, because it's going to suggest that certain networks are going to be more likely to have access to a wider range of people than others. And you might suggest that that's fine. You just leverage those folks that are most likely to be network ties. But what about people whose networks are relatively smaller and local and marginalized relative to other places where you might turn? So just some food for thought in thinking about that. Okay. Well, what about the other two ideas that I raised? The notion of using and turning to the internet for broadcast messages and banner ads and that type of advertising, or using searches and leveraging search engines. Okay? We had an opportunity to look directly at this empirically in the recruitment for a text messaging-based smoking cessation program that I'm working on with Linda Squires and some colleagues over at RTI for NCI right now, the Quit Text program. And what we needed to do was to get people enrolled, and we are still in the process of getting people enrolled to this intervention. So ultimately, there's all kinds of excitement about what might be possible once you've got people to the table and they give you access to and grant them the ability to text. But how is it that we get them there in the first place? Well, what we were able to do is actually track referral source to the landing page for the sign up for this. And we were able to look at some interesting patterns. And because we were out there in all kinds of different venues. We were out there in Facebook, we were out there in other internet applications, advertising, and we also were trying to optimize search results and to get people to the table in that regard as well. What we found, what was interesting, is that there's certain things you can screen for demographically, obviously, to look at and make sure that you're getting the folks that you want to the study. But there was something subtle that happened along the way that I think is worthy pointing out for this discussion today. What we saw was, as a function of referral source, some really important differences in baseline motivation to quit. And this might be common sense, it might make sense to you to think about, but nonetheless, I think this is a really important observation. What we actually found was that those that were coming by virtue of search engines, as you might expect, were much more likely to actually be motivated to quit over time than folks that happened to come into the study more tangentially by virtue of other banner ads. Folks that might have been attracted by virtue of, for example, the incentive that was offered. Okay? That is something that matters, I think, in distinct ways, because there is going to be an issue of generalizability, depending upon the degree to which you're leveraging these types of avenues, and the degree to which that's going to have a subtle difference on who's actually in your intervention, and to what degree you might generalize beyond that. Okay, so quick tour then through some of these notions, ways to leverage and use new technologies to recruit to intervention. I think there are a lot of exciting opportunities. And my main point here, though, today is just to point out that there are important constraints. There are constraints worth theorizing about, and this is worthy of our discussion, despite these numerous opportunities. I think social network strategies are undoubtedly exciting. We just need to be careful that we're not reifying disparities along the way. And disparities that don't necessarily map onto the demographic digital divide that we're used to thinking about, but rather disparities that have to do with the nature of one's engagement with information and tendency to share, and other more subtle aspects of characterizing people. And so is it the case that we're more likely to get to some folks as opposed to others? Are we certainly likely to see certain networks more likely to be active and engaged than others with regards to referral to studies even? With regards to these other two notions, it's the case that, as is often the case, broadcast approaches might get relatively unmotivated people to the table, and that might be okay, and I'm not suggesting that there's value judgment in either case, but rather just to point out that search-based strategies may end up yielding something different than you're often going to be seeing by virtue of folks that are clicking through on an ad. Search-based strategies, at the same time, are also going to be limited in reach, and so there's going to be another trade-off. And that's going to be one of the themes, I think, of our discussion today. Lots of considerations of different trade-offs, and that we're not necessarily assuming uniform possibilities with regards to all of these different avenues. Okay. So with that in mind, hopefully I've been sufficiently pithy. We'll see with your questions if I've been provocative, but I thank you for your time.
Thank you, Brian. So our final speaker in this session is Dr. Carol Golan. She's an associate professor of medicine and health behavior in the UNC Schools of Medicine and Gillings School of Global Public Health, and she also directs the Social and Behavioral Sciences Research Core of the Center for AIDS Research here at UNC. She's engaged in research on the development and assessment of behavioral interventions to enhance medication adherence and health care for persons living with HIV and AIDS, and access to care for incarcerated persons. In addition, she studies the influence of patient-provider communication on health outcomes, and is particularly interested in the effects of enhanced patient participation in medical decision-making, including the use of motivational interviewing to enhance patients' involvement in their own health. Welcome, Carol. Okay. Oh, I see what you did. Okay, great. Can people hear me? Okay, great. Thank you, Catherine. I'm going to shift gears just a little bit and talk about a study that is ongoing right now. Texting to stay healthy after prison release, learning lessons from Project Impact for prisoners living with HIV. And I say learning lessons because it is ongoing. We're in the middle of this study, and so we're sort of learning as we go. Here we go. So just a little bit of background for those of you who are not in the field of HIV. Treatment as prevention is an approach that's now advocated for HIV to improve both personal as well as public health. So the idea is that by enhancing the detection of people living with HIV and then engaging them in care and then enhancing their antiretroviral therapy adherence, we can sustain viral suppression. And this then leads to reduced transmission as well as better health for the individual. Also, for those of you who don't know, prisoners suffer a relatively high burden of HIV compared with the general population. So the prison settings can offer opportunities to test high-risk populations, identify them, and provide them with effective care. And we actually have a criminal justice working group here in our CFAR who studies a variety of ways to do this. So the idea is, and we have studies that have shown that during incarceration we have enhanced diagnosis, we have effective medical care, effective medication regimens, and people are actually very adherent and have very well-suppressed viral loads. They get good care and do well while they're in prison. So then the question is, when they go back into freedom and back into the outside world, how do we maintain those health benefits of care experienced during incarceration? And we think that linking them to care and helping them adhere to their medicines is what we need to do. It turns out, though, when we look at studies, the health benefits that are accrued from effective HIV care in prison often are lost after release, so we need to do better. Turns out that most HIV-infected prisoners receive no or inconsistent health care when they're not incarcerated. And that, combined with, if it happens, which it sometimes does, a return to HIV transmission risk behaviors by the releasee who's living with HIV, and then coupling that with the loss of viral suppression that it can occur if they're not in care, it sort of creates this perfect storm for the transmission of HIV after release into communities. And the post-release period then presents the greatest challenge for prisoners in maintaining adherence to care and antiretroviral therapy, partly because they also have many, many competing demands and difficulties in their life at that time in their lives. This is counterintuitive to hit the right side. So our objective then was to, in this study that I'm going to talk with you a little bit about as an example of using text messaging, was to provide a bridge to health and freedom. And this is a complex conceptual model that we based the development of our intervention on. And I'm not going to go through all of it, but just to say that, first of all, because of the many barriers to adherence and care, we developed a multi-component intervention. You can see that the text messaging here is just one small component that addresses some of the individual barriers, but there are also institutional barriers and community barriers. And so we designed a link coordinator and my counseling, as well as the text messaging. And I'll talk with the specific components in a moment, but that address both clinic attendance as well as community service utilization, which can affect antiretroviral adherence, improve viral load, and improve transmission. So that was sort of our overall goal. So to do this, we developed Project Impact, which stands for Individuals Motivating to Participate in Adherence, Care, and Treatment. We have 4 co-PIs that are listed here. Our objective in this study was to first create the program Impact, which is integrated and adapted our existing linkage, adherence, and retention interventions for released prisoners. So we adapted it for prisoners specifically. And then to compare it in a multi-site, randomized, controlled trial. And I think you'll see some of the issues that were discussed when we first designed this intervention and designed the trial. The technology has really evolved based on what we proposed in the in the grant, and we are still testing sort of this original text messaging in this long trial. But we're conducting a trial with ultimately 400 inmates living with HIV in one of two states, North Carolina and Texas, and we're comparing the standard prison release with our impact intervention, the augmented test, link, and retain program. And our outcomes, our intermediate outcomes, are the medical care appointments and antiretroviral adherence, with the idea that these would then ultimately affect our primary outcome of suppressing viral load at 24 weeks. So I said this is a multi-component intervention because prisoners face so many difficulties at accessing care. We sort of, in this trial, are throwing the kitchen sink at them, which makes it difficult then to see which components work. But we really wanted to try to be efficacious in this first trial. So they get impact videos. It's 4 components, these videos that they get to introduce the program and model staying healthy. Motivational interviewing sessions, both face-to-face in prison, as well as 6 times after release over the phone. Brief link coordination, so a link coordinator assesses their needs and communicates that to the clinic and makes an appointment for them 5 days after release, within 5 days, and starts their drug assistance paperwork. And then finally, the components that we're interested in today, text messaging to facilitate antiretroviral therapy once they're out of prison. This shows sort of visually that schema of the intervention. The diamond in the middle here represents release from prison, so they get 2 face-to-face motivational interviewing sessions in prison, meet with the link coordinator who does the needs assessment, connects them with clinic. Once they're released, we meet them 1 day after release, give them a cell phone. They get 6 phone-based counseling sessions, and this represents the text messages they get, which is what the focus of today is about. And this is just to remind me to tell you that the control group also, everyone gets a phone, but they don't get any of this other stuff. So these were uncharted waters for us. We hadn't done a text message-based intervention. This has never been done among prisoners. At the time, as I said, that we wrote the grant, there was very little data to tell us how to do this. And while it seemed sort of reasonable when we wrote the grant, as Seth said, when you sit down to actually do what seems like a simple text message intervention, it turns out there's a lot of decisions that you have to make. Some of them are technical, and some of them are practical, and some have to do with the message and how and the behavioral intervention itself. So these were the questions that we faced when we sat down to actually try to do this. First of all, how often should we send these messages? Should they be linked to, and again, this is specifically to help them adhere to their medicine. Should it be linked to the dose each day? Should it be daily? Should it be weekly? Should it just be a reminder, or should there be something inspirational or motivational about the message that they get? Should it be something standardized, or should it be something that they write themselves that's more personalized in some way, as Beth mentioned? And at that time, there were no data to really direct us about that, or very little data, particularly in HIV adherence. How much interaction should there be? Should there be this back and forth, did you take your medicine, yes or no? Well, don't forget to take it. How much should we go back and forth with that? Along those lines, how many follow-up texts should there be per dose? And how long after release should we continue to send the text? Should it be forever, or are people going to get tired of it and then it's going to have sort of a negative effect? Are people going to get dependent on it, and then we're going to need to wean them from this? They're not going to be able to remember on their own because they're getting these text messages. So how do we handle that? So those were sort of the message questions we had and decisions we had to make. Then there were these technical things. Should we contract out the work, or should we program it ourselves? And as we investigated the cost of contracting out and looked at what they would actually do, it turned out that we were already doing so much programming for data collection that it made more sense for us to just do this ourselves, or have the SHEP Center do it for us, our data managers. We also were worried about the fact that prisoners may lack familiarity with cell phones, and this could be, you could see this globally potentially as well, but this was maybe something particular to prisoners where cell phone technology was developed while they were in prison. They had never used or heard of a cell phone before, and they may be very intimidated by the changes that they face. Maintaining privacy with HIV, stigma is really an issue, and so how do we maintain that privacy? And how do we handle and time the messages that weren't responded to? Because it became really obvious that sometimes people turn their phones off or their cell phone dies and then they don't respond to the message. Which one didn't they respond to? And how do you handle that? And then linking the message, just some practical things of getting the right message on the right phone with their particular individualized dose schedule. So because there were no data, we did some formative work. We sat down and talked with 45 people who had been incarcerated before, were living with HIV, and now are out. And we sort of talked with them a little bit about their experiences and what they recommended in terms of remembering to take their medicine and in terms of texting. And what we found is that, not surprising, many individual and structural barriers were reported to attending medical visits and adhering to their medication after release. Lack of food, housing, transportation, employment, health insurance, no social support, mental illness, substance abuse, all of the things, competing demands that I have listed up here, were things that really got in the way of people remembering at that, especially that first month, to take their medicine, whereas they could do well in prison. They're out, and all of a sudden, there's just other things that are more important. So they felt that it could be helpful to have a reminder. But they also talked about this fear, distress, and just the challenge of confronting a whole new world that included new technologies, but sort of represented this scary new world that's different from when they went into prison. And then, of course, these fears associated with HIV-associated stigma, compounding the stigma related to incarceration. And this is just one quote. One person said, there's a stigma once you get out of prison and tell people you've been incarcerated, and there's an even bigger stigma when you tell people that you have HIV. So if text messages are going to expose that, they were worried about that. So based on that and just some practical decisions we had to make, we had to move forward with the intervention. Here are the decisions that we made. So how often to send? We decided that it made the most sense, since people needed reminding, to link them to the dose, each dose. We decided to make it more focused on reminding rather than us coming up with sort of inspirational messages. However, as you'll see, some people picked their own messages that also had an inspirational or motivational component. Standard versus self-written. We decided to give them a choice of either. We had examples of standard messages they could choose, but if they wanted to come up with their own, we allowed for that in the programming. Degree of interaction, we ended up actually with very minimal interaction, and some of that was very practical reasons of difficulty that they were going to have with entering their responses with a lack of familiarity with cell phones. And so we ended up with just one follow-up text per dose, as I'll show you. And we decided to continue the text for the entire duration of the treatment. We decided to program it ourselves. We gave everyone free non-smartphones because of their lack of familiarity with cell phones. We trained them, and we had to program the cell phones to accept all values of each button. And I guess it's hard to see on here, but for example, a number 1 might have an asterisk, an A, a B, and a C. If they press that button too many times, they get the different letters, and we had to do programming to take that into account. We had to offer coded messages to maintain privacy and enter the dosing schedule into the system for release. So this is what we ended up with. So you can see here the participant gets text 15 minutes before, take your morning vitamins or your medicine or whatever code phrase they come up with. It waits 15 minutes and then texts them, did you take your vitamins? Or whatever phrase. It says, please reply and press the 1 key for yes or 2 key for no, and then send. If they respond no, within 1.5 hours, we wait 30 minutes and send one more question. That's it. If they respond yes, we send them a message that says, thanks for letting us know. And that has to be within 2.25 hours of the reminder. If they don't respond, then we just stop. We don't do anything. This just shows you, and I'm not going to go all through this in interest of time, but it shows you we have 282 of the 400 enrolled so far, about 142 in the intervention arm, 107 that have actually been released. Some are still awaiting release. Some never got their cell phone. Remember, at release is where they get their cell phone. 33 have completed, 53 are still enrolled, and 21 are lost, died, or in prison. Most of those are actually in prison. This shows you some of the demographics. It's mainly men and African Americans. A large proportion with low education, and relatively good health status for a little over half. So do participants prefer standard text? 39% selected the standard text, 61% designed their own text messages. Did they prefer reminder or inspirational text? 75% chose reminder and 25% more inspirational text. And here's what they picked. 21 said just take your medications or take your vitamins. 10 had something about their animals, feed the dog, cat, or one person actually had a pet ferret, F-E-R-R-I-T. Read the Bible or pray. And a number of people picked this. Others sort of linked to watching the news, exercise, eating, taking out the trash, things like that. But we also got sort of one-off choices. YOLO, you only live once. That expression, bow down, your kids, tell your kids I love you, just do it. Remember who you love. Sweet dreams or beautiful nightmare, and look for the shining star. So personalized messages to themselves about what they thought would remind them. Do they respond back to the text? So it turns out, and this is the total number of texts responded to date, most people either responded or didn't. So there's very few that responded and said no, and then got another text. So basically we've sent about 9,000 to date. About 45% of those messages were responded to. Along those same lines, the proportion of people responding to the text. So there's about 7.5% of people who just didn't respond at all. They didn't, they just ignored it. About 5% who responded to essentially every single text that they got. And then you can see about 4% responded most of the time, and the rest, really varied. It was a huge range of how many they would respond to. This is just an example, and it's too small to see, so I've just kind of pulled out a little piece of that here to show you an example of what happened. At 6:45, we sent the reminder to the participant, remember to take your cholesterol medicine. This participant, although they didn't have to, wrote back and said, thanks. Then 15 minutes later, did you take your cholesterol medicine? Please reply, pressing 1 for yes, 2 for no, and then hit send. They wrote out yes. Sent to participant. We didn't understand your response, yes. Please just respond by pressing 1 for yes or 2 for no. And then we remind them any character on the button is fine. They send a 1. Thanks for letting us know. Again, they don't have to, but they wrote back and told the machine, you are welcome. So it just shows you how much people really feel that this is personalized, even though it's really a machine sending these responses, through an algorithm. Did they find them useful? 38% of people just turned them off at some point during the 14 weeks, whereas 62% just kept them the full time. And the point at which they turned them off ranged from at the very beginning to almost near the end. Lessons learned from the interventionist perspective. Overall, participants like the test messaging and find it beneficial, but participants on both sides of the spectrum of familiarity with technology find it a bit challenging. So those that are familiar with technology and adherence may find it too simple and annoying. Those less familiar found it very frustrating trying to respond and figure out how to press 1 versus 2. And I'm not going to read through these, but essentially they reiterate the same thing, that some people found it challenging, but most people found it helpful to have a reminder within the first week. I'm going to skip over these data and just summarize. So in terms of technical issues, programming auto responses appropriately for every possible scenario was really challenging, and avoiding follow-up text to non-response and limiting responses for no responders helped us to reduce this challenge. Most individuals living with HIV after release from prison appear to find these text messages useful, particularly to remind them to take their doses, but some chose very motivational reminders as well. Most wanted to design their own message,
And about a third elected to turn them off at some point. They found them not to continue to be useful. In terms of feasibility, some found it challenging, as I said, particularly those incarcerated longer who had less familiarity with the newer technology. Most were able to use a phone, however, with training by our research assistants. Some did become reliant on these messages and even become attached to them or attached to the program that was sending them these messages. And so for those, we did have a transition process where the counselors would train them to maybe set an alarm or do something else. And the rest is stay tuned. And then finally, I really want to thank, there's a huge team of people that worked on this, and a particular thanks to Jessica Carter-Otten, who may be in the audience here, and Jennifer Groves, who I think is as well, because they really did the heavy lifting here in terms of running these analyses, these sort of preliminary analyses quickly so that we could share them with you here today. So thank you very much.
A few minutes, if all the panelists could come to the stage and we can get a chance to ask them all questions for a few minutes before we break for lunch. So does anyone have any questions to start off with?
Hi, that was a great presentation. Carol, I have a question about your last comment about something that was being attached to their cell phone. So does that suggest that maybe there could be some benefit from having the ability to use that phone and keep those reminders coming to them?
Yeah, and essentially that's exactly what we tried to do, not the reminders themselves, but to teach them how to create a reminder for themselves.
I mean the interaction, that maybe they actually, they think it's a machine, they know it's a machine, they may treat it as a person, but it is contact with some supportive environment. That's different from having the alarm on your phone.
Yeah, I think that's right, and I think that speaks to what Seth talked about earlier about the interactive and sort of personalized nature of these, showing that they're likely to be more effective. You know, obviously for purposes of the randomized trial, we had to stop the intervention at some point so that we could get our kind of post-intervention measurement. But I think you raise a good point. I don't know if others can speak to this, maybe Kelly, in your experience with the text messaging as well.
Yeah, absolutely. I say mobile phones are your friend, and people, even though they literally know that it's not a person on the other end, they often don't really process that. And so they think that there actually is a live person on the other end. And that is, in my perspective, one of the powers of mobile phone messaging is that you can automate a lot of these processes. So they can be very low cost and can be scaled up because of that. And people often think there is a warm human being at the other end of that communication. So it's very powerful that's one of the reasons that phones are so powerful, I think.
Actually, I have a quick follow-up question for Carol for a practical level. Sorry to grab the microphone, but just in terms of thinking about how these cell phones fit into everyday life and patterns of technology adoption, did you screen for, or were these folks, none of whom had their own private cell phones? And if so, I mean, just thinking historically, likely quickly thereafter they might have gotten obtained other phones. How did you find that they were able to juggle your phone with theirs? And did you run into any evidence in that regard?
Yeah, I think it's a really good question. I think it's more of an issue in studies that don't involve people just getting out from prison. Mm-hmm. So a lot of these people don't and wouldn't have otherwise had access to a cell phone, which is also why one reason why we provided cell phones to both groups. It also made for sort of a cleaner design. It also made it a lot easier in the setting of research to retain people and to get in touch with them. But I think, in other settings, and we face this in sort of trying to design some other studies where you have to decide, is it going to be, easier to have the person using their own phone, but then maybe not everybody's going to have a phone. There's also technical challenges with trying to do programming that's going to work with multiple phones, as Kelly may have experienced. So those are all issues, I think, in designing a study that have to be taken into account.
Yeah, Yeah, now I'll add to that. I'm not a big proponent of giving people phones. We encounter a lot of different problems with them. There's also this conversation around in order for a mobile phone intervention to be successful, ideally it's ask people to use their phone in a way that they're already using it. So that if they're not used to using a phone, if they're mobile phone naive, or they're being asked to have some type of interaction with their phone that they don't typically have, then it's more of an uphill battle, and it's something that's much harder for them to, integrate into their behavior change or health promotion. So, but there's definitely a conversation around whether that's a good thing or not.
Yeah, and those are all definitely things we took into consideration. I think we let them keep the phone, but we were paying the data plan, and so then it would be up to them to continue with the data plan if that was something that they wanted to do. The other thing I should say about giving, there was a lot of concern, maybe partly on the part of the study section, but about giving cell phones to prisoners and that they would be lost or stolen or that kind of thing. And we had very, very little of that. We had a little bit, and I don't know if Jessica's here, we have had a couple problems. There's another, I guess, practical consideration with overusing, not the texting because that was unlimited, but overusing some of the voice, running over their minutes for talking, and we had to come up with ways to lock the phones to only go to certain numbers. Some people were very good at figuring out how to get around that, but most people didn't try to do anything like that. So good experience with that.
Okay, I think we have time for 2 more questions. Yes, Deb?
That was great. Brian, I had a question for you. I thought it was fascinating about the motivation of those who are using the search engine versus the click-through ads. And so can you give us a sense of the proportion of the sample that's recruited with both methods? I was thinking one way or another, and I wanted to see what actually is.
Yeah. So actually, as it turns out, and this is enough for us to be able to make that initial comparison, roughly comparable in terms of the numbers that were coming in through both means. It's just they were at different ends of the spectrum in terms of where they were in motivation. So something that we worried about was, imagine if we relied exclusively on one or the other, what you might end up with in terms of variance on motivation, baseline motivation, kind of going into the study. Now, that said, I'd be interested to hear what your speculation is. This is a few hundred people under limited circumstances, kind of thinking about issues of reach and whether or not it might be under some circumstances something you could live with and have a wider broadcast strategy that you're bringing in lots of folks regardless. But Deb, what do you think about that?
I was thinking that oftentimes the research is criticized for recruiting advertising, saying that they're the most motivated because they're responding to an ad that happens just in time. But you found that actually people that are searching out whatever the program is are even more motivated and quote unquote the motivated to respond to advertising. So I just think that that's an interesting finding. First, I wanted to speak to potentially what we kind of think about people who are recruited into research through ads.
Absolutely. Now, maybe what we've done is just find a group yet further down that road, and then still both of those methods require some thinking about generalizability, and there are other avenues you could take to recruit folks. But actually, in this particular case, we did find that we're seeing a fairly broad range coming in through the ads and just this clustering of folks who were in the search group. Yeah, it's a great question.
Let me just kind of add something that's just tangentially related. So with our Mobile for Reproductive Health program, it's an opt-in or an on-demand system, so you have to know about it in order to use it. And so one of the interesting things there is that we're not pushing out messages to people unsolicited, right? Like people have to actually want to get information about family planning, about health services, or what we find is a lot of people are just curious about what is this, this is kind of they want to see what it's about. And so what's interesting is when we think about who we're reaching along kind of the behavior change continuum, we're already over a little bit, right? We're not in the real, hardcore pre-contemplation stage of who we're actually reaching with this messaging. And we recognize that and actually think that, you know what, you can actually put a positive spin on that and say, that's great, that people who should be using this, who are most likely, to actually have this impact their behavior, are the ones who are actually accessing it and getting information this way. So,
I mean, it raises really important considerations in terms of scalability, but at the same time, it's through these technologies we're able to really effectively deal with, pardon the metaphor, but low-hanging fruit, or that's fine. I mean, that's worthwhile. It's just we have to be careful not to extrapolate from that to assume that those results, if you were to go nationwide, necessarily would be quite the same. It's just a nuanced observation. It doesn't undermine the. As long as you keep that in mind.
Okay, I think we have time for one more quick question. Yes. Yes, next to you. Mm-hmm.
Yep. Right. So, I mean, we can think about the full array of places where you might, advertise on the internet. So, I mean, that's maybe less, important in terms of, an example. But, there are a couple of, aspects of engaging with, search engines now. There are possibilities for, optimization. So it's strange to think about that as a recruitment strategy, but nonetheless, actually, trying to optimize according to and trying to break code with regards to Google algorithms, and to make sure that you are well placed, and then to wait and see. And in this particular case, we've been pleasantly surprised that folks have come in the door that way. In terms of the range of options for peer-to-peer possibilities, there are myriad, right? And so you might think about instances where you make possible, electronic referral. Everything from an invitation to intervention that is easily forwardable by virtue of email or a Facebook message, something that's easy enough to paste to one's social media site. But then there also are other ways, and this is an underappreciated aspect of the work that we do, that we might draw upon, thinking about interpersonal interactions, ways that we might facilitate conversation in all kinds of ways, even offline. Instances where we might try to spark conversation about the degree to which you are able to arm people with and to facilitate the easy transfer of information in those interactions. I think that's really where the technology is or where exciting opportunities are headed. There's a twist here and an interesting aspect. So here's a lot of us are talking about text messaging. And it's quite difficult from a push standpoint, a broadcast standpoint, that you can't send people text messages that they don't want. You might think about messages that are, pithy enough to be forwarded. I mean, that's a possibility, but there are some complications there. I'd be interested to hear both of you talk about, where we get excited about this, but in terms of thinking about leveraging that within networks and the degree to which the messages themselves are moving on. I don't know, Kelly, if you had any ideas about that.
Brian, that's the collaboration that you and I need to do together.
Well, we meet at places like this.
Yeah, I mean, we know that people, with our family planning messaging program in Africa, we know that people are forwarding on those messages, and not only are they forwarding on, but they're also using them. I talk about what I call text message literacy, right? And I think it actually is different in a lot of the developing countries that I work in, where people actually they use their phones differently often than they do in Western countries, where the use of a mobile phone is often a much more social interaction, right? So people might get our messaging about family planning, and then they might not understand all the words in it, and so what we find is that they'll actually go to a partner or to a healthcare worker or to a friend, and there'll be a small group of people there, or a dyad who's actually looking at it and consuming that information together. And so then your amplification and your diffusion happens in a really different and kind of unexpected way, that if you could figure out how to actually track what that diffusion is like, it would be incredibly informative.
So think about even just So the instance where you are getting forwarding, privacy reasons and others, just from a very practical standpoint, there are some instances when you might be able to get an instance of a message pushed out and forwarded first level. But beyond that, it's very difficult right now, as we understand it, to track that. So as I think from a very practical evaluation standpoint, I'd love to get my hands on that, but there are all kinds of reasons why we can't at the moment. But Carol?
No, I was thinking about that. It's hard to track.
Absolutely. I'm not quite sure if that answered all of your questions, but we can talk more about that later too. Great.
Yeah, please find these folks during lunch as well. I don't want to cut into too much of the poster presenters' time, so let's give everyone a hand. That was a great session.